Bronchiolitis obliterans. NB. Do not confuse bronchiolitis obliterans, BO, with cryptogenic organizing pneumonia, COP. Both conditions differ clinically, radiologically, and histologically and in their responsiveness to steroid treatment. Etiology. BO is characterized by mainly irreversible airflow obstruction that is usually progressive. It occurs mainly in lung and heart, lung allograft recipients, and is the major cause of lung allograft rejection. The most common cause of non-transplant BO is connective tissue disease, especially rheumatoid arthritis. Other less common causes include toxic fume inhalation, infection, viral and mycoplasma pneumoniae, drugs, penicillamine, radiation, and ulcerative colitis. Pathology. The hallmark of BO is submucosal bronchiolar fibrosis that is preceded by bronchiolar inflammation resulting in epithelial necrosis. As a result of this, the bronchiole becomes plugged by granulation tissue. Subsequently, collagen is formed, which may completely obliterate the airway lumen. Clinical presentation. This is often nonspecific and insidious. The most common complaint is exertional dyspnoea, often accompanied by a chronic productive cough. Lung and heart. Lung allograft recipients may present with a decline in their forced expiratory volume in 1 second, FEV1, see section 2.13. Physical signs. These are often unremarkable in the early stages. In more advanced stages there are signs of hyperinflation, end-inspiratory crackles, squeaks and wheezes. Investigations. Pulmonary function tests, to look for an obstructive defect. CXR, initially normal or may show hyperinflation. As the disease progresses, subsegmental atelectasis, loss of volume and/or fibrosis may be found. High-resolution CT scan of the chest. Radiological appearances are quite distinct from those of COP and reflect underlying airway obstruction. For example, bronchial wall thickening of the segmental and subsegmental bronchi with mosaic perfusion is clearly demonstrated on CT scan carried out during expiration. Lung biopsy, the only method of definite diagnosis of BO. However, this may be difficult because the diagnostic yield of transbronchial biopsy in BO varies between 15 and 82%, due to the patchy nature of BO and the small size of biopsy samples obtained during the procedure. Video-assisted thoracoscopic lung biopsy should be considered if transbronchial biopsy is inconclusive or atypical. Arterial blood gases, hyposemia and hypercapnia develop in end-stage disease only. Differential diagnosis. Consider asthma, emphysema, desquamative interstitial pneumonia and hypersensitivity pneumonia. Treatment. There is no reliable therapy. Unlike patients with COP, those with BO usually respond poorly to corticosteroids. Various immunosuppressive regimens are used to slow the rate of decline in FEV1. Prognosis. BO has a variable course. Some patients present with a rapid decline in FEV1 and are likely to die within a year of diagnosis, whereas others show progressive slow deterioration. Overall mortality varies from 25 to 56%, and most patients die of infection or respiratory failure.